morning, everybody. Welcome to MSU and Sparrow Pediatric Grand Rounds. I would also like to extend a warm welcome to our colleagues in Flint and Grand Rapids. Just before we get started, I have a couple of announcements. Today at subspecialty rounds, the pediatric floor team will give a case presentation. Please join us next week when Dr. Vijay Naraparaju presents Preventative Pediatrics Injury, Prevention and Safety. It is my distinct pleasure to introduce this morning's speaker, Dr. Scott Maurer. Dr. Maurer is very well known to all of us. He's an assistant professor of pediatric cardiology at the University of Michigan, and he practices with the Lansing Group based here in the Sparrow Professional Building. Dr. Maurer obtained his Bachelor of Science degree from Michigan Technological University, biochemistry degree from George Washington University, and his medical degree from the Uniformed Services University of Health Sciences at Bethesda, Maryland. His pediatric residency was at Portsmouth Naval Hospital in Portsmouth, Virginia, followed by a pediatric cardiology fellowship at the Medical University of South Carolina. Dr. Maurer has lots and lots of interesting stories to tell about his years of service in the Navy. He served as a physician in the Navy, both nationally and internationally, as far away as Okinawa, Japan, where he had the opportunity to practice on general pediatrics, despite the fact that he was a qualified cardiologist. He's particularly interested in medical education and has given several lectures to several groups of people in various settings, PAs, EMTs. He has designed adult cardiology curricula and has been an invited speaker at several conferences, mainly on pediatric chest pain. He has occupied several service and leadership roles and has won several honors and awards, especially teaching and leadership awards, and several awards in the Navy as well. He has no conflict of interest to report in the preparation of this talk. Please welcome Dr. Maurer as he presents Kawasaki Disease. The guidelines have just been updated, but what's really new?
So as you just said, my name is Scott Maurer, for those of you who don't know me, but I think I know most of the people here in the room. And you may be aware also that I am with the University of Michigan, and although we're under the shadow of Michigan State, U of M does pay the bills. The outreach program is part of a collaborative effort on the part of Pediatric Cardiology to establish pediatric cardiologists in communities where there may be a need for such, to sort of share our our cardiology expertise with you, but be aligned with the community. And I think here we're showing that we're a good example of that collaboration. I live here, my kids go to school here. I take call at Sparrow, I don't take it at U of M. So although I wear the U of M colors, I'm more aligned with Lansing and Sparrow than I am with U of M. That being said, shameless plug, University of Michigan is ranked the third best pediatric cardiology program in the United States. So just shameless, I'm sorry about that. So anyway, our talk today is about Kawasaki disease. The guidelines have just been updated, but what's really new? And as I mentioned, I have no industry relationships or financial relationships, but I have a personal disclosure. If you know me, and I've lectured before, the tendency is to try to cram as much as possible in that time frame at the risk of running late. And today will be no different. So I hope you can hang with me, because I hope it'll be valuable. But meanwhile, I am going to run through some of this a little fast on the stuff that I consider that you would be familiar with. But hopefully, if you miss it, we'll catch up at the end of the talk. The objectives are, again, to, the instructions or the guidelines for Kawasaki have recently been updated, literally last month. So I'm going to review kind of the epidemiology, pathology, diagnosis and treatment, and in the context of mostly where it's been updated in the new instruction. Specific points in this new instruction I'm going to spend a little bit of time on is that the algorithm used to evaluate incomplete Kawasaki's has been updated. There are additional therapies and that are used for refractory patients or adjunctive therapy that we'll talk about. Some of the cardiology stuff, there's been a lot of cardiology updates in this, including how we cut off and make criteria for coronary artery enlargement, and updated the protocols for long-term management. So this is one of the first really big articles really kind of reviewing Kawasaki disease. This is published in 2004 by Jane Newberger and colleagues. And this was really, this is what I call the Kawasaki Bible for a long time, because it really reviewed, really nicely tied up and reviewed details in diagnosis and management of Kawasaki disease, and for the first time published an algorithm to assist us in diagnosing those who are having incomplete Kawasaki's. But this is the new instruction, and you may notice this has actually hit the presses in July of 2017. This is hot. This is Africa hot. This is smoking hot. So I wanted to kind of bring it to you. The first time I presented something on this topic, I thought, oh, it'll be really easy, just an update, but it's 74 pages long. Much of it to do with cardiology stuff, but some of which applies to you. Some of the things that are not changed is mostly in regards to the definition and epidemiology, signs and symptoms, but I'm still going to review some of that. So by definition, it's in a self-limited vasculitis. We don't know what the etiology is, but it does affect the small and medium-sized muscular arteries. It does not affect the elastic arteries. Primarily, it affects infants and young children, and most of the KD symptoms will resolve spontaneously and completely without leaving any residual issues. But there is a subpopulation who are affected with their coronary arteries. That comprises the major morbidity and mortality associated with Kawasaki disease. And it is the most common cause of acquired heart disease in developed countries. In undeveloped countries, it's rheumatic fever. And this is kind of the target. This is the big panel over here is a MRI angiogram reconstructed in 3D. And this right here is a big aneurysm in the left anterior descending coronary artery. If we strip away all the heart, isn't this cool, this technology? You can really see that the aneurysm in the left coronary and then also one in the right coronary artery. And that's really kind of our goal, is to try to treat these children to avoid aneurysms if we can, and then if they're there, to treat them properly to avoid morbidity. I found this absolutely fascinating, is that the Kawasaki disease has been described for some time, but somebody dug up this case report from 1871. This is amazing. A case of morbid anatomy, aneurysms of the coronary arteries in a boy. That has to be Kawasaki's, and it's from 1871. But they probably didn't know what they were really doing with that. They probably didn't know what that was. It was just a case report. In the 50s and 60s, there was an entity kind of in our more modern area called polyarteritis nodosa, which for all intents and purposes was exactly like Kawasaki disease, except the association with coronary artery aneurysms hadn't been made. That association had been made by Tomisaki Kawasaki in a report in 1967, and that's kind of the start of the modern era of Kawasaki disease, was from that point on. Epidemiology hasn't changed a lot. Boys get it more than girls. Most of these children are 5 years old or less. The peak age is right at about 11 months old. And on the far end of the spectrum, only 1 or 2% occur on the far ends of that spectrum, either prior to 6 months of age or after 9 years of age. But it is of note that it rarely can occur in infants even less than 3 months old. This diagram is pulled from an article in 1995, panel on the left from 1991, the panel on the right from 1992. Again, showing the sort of distribution with the peak age at about 11 months of age, with males being more common than females. But look at how amazingly similar that is in an article printed in 2015. Same distribution, same average age, same age range. That hasn't changed over the decades. It can recur at about 3%. Most of the epidemiologic data comes from Japan, where the incidence is much higher than it is in the United States. And so it recurs with a rate of about 3% in Japan. In the United States, the overall recurrence rate is 1.7%. But again, if we pull out the Asian Pacific Islanders, we find very similar to the Japanese data. It can recur in about 3% of them. This is kind of showing a distribution of those recurrences. Again, it occurs in about 3%, especially those of Asian descent. Older kids seem more likely to have recurrences if they're going to have recurrences. And in a tiny fraction, 0.2% may actually get it more than twice. So if it's going to recur, in males, it seems to be about 3 to 5 months most often after their initial diagnosis. Females about 9 to 11 months. And this, again, is showing that distribution of recurrence, but maybe as long as 4 or 5 years out, potentially. It does have a seasonality, and this shows over the course of 11 years, there's the distinct seasonality in which it's more common in winter and spring, and this is repetitive over a decade. And that seasonal variation occurs throughout the northern hemisphere, but interestingly does not occur in the southern hemisphere of the tropics, and we don't really know why that is. Epidemics do occur. This is demonstrating an incidence graph in Japan, in which there are these huge spikes where we get these huge numbers of cases diagnosed, in this case in Japan in 79, 82, and 85. And this overall general increase is just through greater education, but also the incorporation of incomplete Kawasaki disease. We see this general trend of it going up. But these epidemics are not isolated to Japan. They're also been seen in New York, Massachusetts, and Hawaii as well. As we all know, the etiology is unknown, despite an exceptional amount of investigation for a pretty rare disease. Kawasaki disease certainly has every appearance that would suggest an infection. The fever, the rash, the labs with increases in white count and inflammatory markers, its response to IVIG, the epidemics, seasonality, but despite that, no single agent has been identified as a cause to explain Kawasaki disease. There are some environmental factors, some epidemiologic studies that imply the role for some kind of unidentified environmental risk factor. A ton of them have been disproved, including antecedent respiratory illness. The thought was that there's a big spike in IgA, maybe there's some respiratory entry, they couldn't find that. Carpet cleaner, I don't know how that was thought to be an etiology, but it was explored and disproven. Humidifiers, mercury dust mites, eczema, all these things were not shown to have an impact, but thought to maybe have some environmental impact. In this report, interestingly, this is some kind of new data to share with you. There are some reports that link Kawasaki disease to tropospheric wind currents originating in northeast China. This is from one of those papers kind of showing in Japan, basically they're pinging the 3 epidemics, and the feeling was that the wind currents seem to correlate kind of emanating from northeastern China, emanating from China, and then the wind currents seem to roll over the places where incidence is greatest. This is from the other article that was cited. Green is 1 year's epidemic, and it turns out that the green part was exactly where one of the epidemics was. The red in the graph is where another series of wind currents seem to carry potentially another run of disease. But each one of these colors sort of correlated, interestingly, to an epidemic, and all those wind currents seem to come from this sort of area in China. The further implications of that are unknown, still investigational, and maybe it will be proven to be like dust mites, that it's not related, but kind of an interesting sort of thing. But it is something that they're still looking for what environmental impact may be causing Kawasaki disease. Another recent study in this paper implies a connection to some perinatal factors potentially related to older maternal age and maternal GBS, hospitalization and infancy for some bacterial infections. But again, this isn't corroborated, but this sort of demonstrates that there's this ongoing push to look for environmental and other factors that may cause Kawasaki disease. In Japan, the case fatality rate is exceptionally low, but it is present. Of those deaths, 38% occur in those less than 6 months. And so I think it's important to point out and remind you that only 1 or 2% of all cases occur in children less than 2 months of age, but 38% of the deaths. So proportionately speaking, that's a huge proportion of deaths that occur in this very young population. The peak mortality is about 2 to 4 weeks after the onset of your fever. This happens to correlate with the period of evolving aneurysm at a time in which they're a little hypercoagulable and the platelets are very high. So at the time they're developing aneurysms, they are also at a high risk of developing clot in those aneurysms. We also know that many years down the road, those people who have had aneurysms may have myocardial infarction. This report was in the paper, in this new paper. And in those adults who had heart attack at pretty young ages, at less than 40 years old, of those patients, about 5% had lesions that appeared to be consistent with missed Kawasaki disease. Meaning these adults at 40 years of age had Kawasaki at a young age. It wasn't treated as such, as either missed or maybe in the era of treatment that wasn't as developed as it is now. They developed aneurysms, and those aneurysms led to long-term risk for myocardial infarction. We know that there's an extensive evidence for genetic predisposition. There's a marked increased incidence in Japan compared to anywhere else in the world. And that is continued in other nations in which the Japanese may emigrate from Japan, but have a population in other countries. We still see that increased incidence maintained in other countries. We also see a familial disposition with siblings and twins having a markedly increased incidence compared to the general population. And this is kind of a combination, again, showing that in Japan, look how high the incidence is. But those of other non-Japanese Asian populations also have a higher rate compared to other races. And then kind of from there in the United States, African Americans seem to be next most common. Hispanics and Caucasians have it the least commonly in the United States. So this table is a little busy, but all I wanted to do is show you that in this new article, they've actually identified a handful of genes that they've linked to Kawasaki disease. These genes have a wide range of effects. Some have to do with affinity receptors for immunoglobulins. Some have to do with the B-cell activation cascade. Some have to do with modulating and mediating apoptosis. It's really hard to say that we see a trend with these genes, but it is interesting that they're finding genetic markers that may sort of increase risk to some degree. So this is increasing, as you can imagine, a lot of excitement that somewhere out there, there's some gene that may be identified in the future that would tell us who's going to be susceptible to Kawasaki disease, who may have worse outcomes, who may be more at risk for developing aneurysms, or those who may respond to IVIG differently. And so with this possibility, there are already currently underway trials to see interruption of this genetic mechanism may sort of alter outcome of Kawasaki disease. So this is sort of Star Wars on the horizon, but they are investigating genetic influences, and they're still hoping they're going to find some genetic marker, some allele that will help us identify those at risk and those not. So now, kind of the overarching theory of Kawasaki, as elaborated in this paper, is that the researchers now feel that Kawasaki disease is probably a final common pathway from some aspect of infection, whether it be the actual infectious agent itself, a toxin, an antigen that creates an autoimmune response that we don't know, with perhaps some impact or influence from an environmental factor that triggers a non-specific vasculitis in genetically susceptible individuals. And this is sort of the kind of the working framework of where we think Kawasaki disease comes from currently. Again, with no specific etiology that's been identified. We kind of drill down histologically and kind of at the molecular level. We see that it's a vasculopathy that affects small and medium-sized arterial vessels. It occurs in 3 stages, with a necrotizing arteritis within the first couple of weeks, with a mononuclear infiltrate, PMNs and then mononuclear infiltrate, followed by this sort of subacute smoldering vasculitis in which the walls of the coronaries are actually destroyed. And then long-term, over many months, this is kind of a concept elaborated in the paper, is this LMP, this myofibroelastic proliferation that occurs over a matter of weeks, months, years, ongoing for years, in which there's this proliferative process of this myoelastic element, not in the architecture of the coronary artery wall. It's occurring in that area, but it's very thick. It's not kind of in the architecture of a normal coronary wall, so it's not responsive to the normal forces that other coronary walls would to dilate or constrict based on sort of physiologic conditions. So it's a version, but it's not true scarring. It's not fibrotic tissue. It's kind of a myofibroelastic proliferation, but it's very nonspecific. In this picture, the upper left is a normal coronary artery with this well-defined layers. In the bottom picture is a coronary artery that's been destroyed by this necrotizing process. Kind of running from about 3 o'clock to 6 o'clock, this whole coronary artery wall has been destroyed by this necrotizing process. And you may or may not be able to see it, but if you follow this here, this is the elastin layer, and it goes all the way out here. That's the aneurysm. This is all clot, and that's all thrombus, and that's why this is an autopsy specimen. And look at all the PMNs kind of in that field. So this is kind of a demonstration of this transmural destruction with this infiltrative process where the PMNs and mononuclear cells sort of destroy the coronary artery wall, and you lead to this coronary aneurysm. The other pathologic process that leads to morbidity and mortality is the fact that these endothelial walls are at increased risk for thrombus and fibrin deposition, just like in the adults. And this is a clot within a coronary artery. So that's the sort of the mechanism that we see acutely, but chronically, there's this computer model showing kind of this flow through the coronary artery, and you'll see that that's not laminar flow going through the coronary aneurysm. There's this sort of circular swirling flow within these aneurysms, and the thought is that this is creating some kind of shear stress on the walls, kind of right at the ends of the aneurysm, and that's why we see this sort of luminal myofibroelastic proliferations, that it creates a shear stress that leads to this sort of proliferation of nonspecific myofibril development. So as you can imagine, that's not a normal coronary, those dilations. Just in general, as a broad brushstroke, we see that the mild dilations and mild ectasias, just these sort of fusiform, subtle dilations in the coronaries, they typically regress with no long-term complications. But the medium-sized aneurysms, the medial layer is diminished, it may be destroyed, they may regress, sort of depending where you are on that spectrum, but they also can thrombosis and stenosis over time. The large aneurysms absolutely do not regress. They persist indefinitely, they can thrombose and cause long-term problems. This cartoon sort of demonstrates that sort of spectrum. Kind of on the upper corner here, we see you can have Kawasaki disease with no coronary artery changes. You can see this mild, transient, fusiform dilations that go away after the acute phase is resolved. But kind of on the bottom here, you see kind of a two-pronged kind of course in which those dilations will fill in with this myoelastic proliferation. And you can see that coronary artery wall, although the lumen has normalized, it's not a normal coronary artery. That coronary artery is not going to be responsive and reactive to vascular changes. And over time, you see the wall of that will calcify and even be more rigid and inelastic. The other time course is during acutely in that big aneurysm. You can see clot formation. Sometimes a canal will form within that clot. But again, that is not a normal coronary lumen, and that can calcify and also cause long-term problems. It does not affect the big, large elastic vessels like the main pulmonary artery or the aorta. But the kind of the small to medium-sized muscular arteries, such as the coronary, seem to be very sensitive to these changes. But it's not just the coronaries that can be affected. There are large, medium-sized, also note that the branches that seem to be affected most are those that lie on the surface of the heart. The branches that dive into the myocardium seem not to be affected by this process for whatever reason. But other arteries can be involved as well, arteries throughout the body. This is a picture that comes from this article and sort of CT angiogram. You can see there are aneurysms in the subclavian arteries, the iliac arteries, and the femoral arteries. And this child also had coronary artery aneurysms. So they can occur at other spots in the body, and we'll touch on this in a little bit in the future, but they tend not to cause any of the acute problems that the coronary artery aneurysms do. So now I'm going to get into kind of the meat of treatment and diagnosis, and I think it's important at this point to sort of throw in this comment that was made by Jane Newberger in her article in 2004, in which she stressed that these are guidelines. These are not intended to be rigid things that have to be kind of followed. These are basic guidelines, and clinical judgment is important to individualize these recommendations to your patients. That is even more true with this new updated article. So the diagnosis with the current criteria you mentioned before was established in 1967 when Dr. Kawasaki sort of described the criteria as they exist today. But the emphasis is that this is a clinical diagnosis. This is your observation of their symptoms. This is not based on some lab or radiology test. There's no thing that will distinguish a Kawasaki patient from a non-Kawasaki patient, and nothing would replace your observation of their symptoms. Lab tests may help provide supportive evidence that may help lean you one way or the other, but the labs themselves don't make the diagnosis. And there have been attempts to identify a biomarker that may help distinguish these populations, but even that has not turned out. They've used BMP and a number of other things. BMP is the one that sticks in my head the most, but even BMP hasn't been able to sort of identify those who are at risk. These are a list of those diagnostic criteria, and this has not changed since 1967. These patients in general should have a fever. The criteria state that it should be a 5 days duration, plus 4 of these 5 changes, 5 principal features. Changes in the extremities, a rash, conjunctivitis, changes within the mouth, and lymphadenopathy. If you have 4 of those criteria and a fever, that's the classic form of Kawasaki disease. Kind of implied in this that there's an absence of no other known disease processes such as adenovirus or measles or whatever that would explain these symptoms as well. But if you notice, at no point in here are there labs or radiology findings. There's no echo finding on this list. This is clinical criteria that any pediatrician could be able to distinguish. This article does take pains to sort of also say that you can make the diagnosis with a shorter duration of fever. If that patient has 4 of those 5 criteria and you're only day 4 of fever, the article is saying you don't have to go, just wait, you have another day of fever to go. You say, no, you have Kawasaki disease and you can treat them with 4 days of fever if you have 4 clinical features. But this article actually goes a little further. It even says that if you have 4 criteria, you can make the diagnosis with 3 days of fever. You can treat them after 3 days. And that's kind of a new part. And that gives you, again, as I said at the beginning, at the very beginning, that this new article is designed to give you more flexibility and more diagnostic responsibility, more clinical impact. But you can make the diagnosis if you're reasonably experienced and you say, this is Kawasaki disease, that's 4 features, and you can treat them early. Because the overarching intent of this update is that they recognize that early diagnosis is important because early treatment is important because nothing prevents coronary arteries better than early delivery of IVIG. So we can make it easier for you to make the diagnosis and get IVIG on board. That is better for the patient. And this is kind of part of their efforts to make it easier to make an early diagnosis. Just really quickly on each of these main features, the fever classically is high, usually over 102 or so, spiking, and antipyretics will help, but the effect is generally temporary. And if you don't treat them for Kawasaki disease, it's not uncommon that these fevers may last for weeks. Even if the fever has resolved after a handful of days, that doesn't exclude Kawasaki disease because we know these features may sort of come and go over time. I have a cartoon to sort of show that. Changes in the extremities are another of the primary features. We show we get a very prominent erythema of the palms and soles during the acute phase. I'm impressed sometimes how much their fingers look like little sausages. They just get this heavy duty, very thickened induration of the hands. It just, you can even see kind of some little bits of redness across the knuckles, and they just seem like just moving their hands is kind of painful and uncomfortable. Desquamation can occur in the hands and soles. It usually starts kind of at the nails and kind of works more proximally from there. But we've also seen desquamating rashes in the perineal area, but that's not one of the primary criteria. Long term, we'll see bovine, because I think the vasculitis sort of causes some inflammation or damage along the nail beds, and as the nails grow out, we see these horizontal lines kind of growing out. That's what a bovine is, but of course that's going to be months out from your acute phase, and doesn't help in diagnosis, but just an interesting finding that we see. So here's kind of an example of kind of the reddened hands, the sausage fingers, the peripheral kind of peeling starting in the distal parts and kind of working more proximally. This kind of a classic picture. Maybe this one's not quite as prominent, but that's sort of what we would see kind of going on in the hands. The rash is very common. Usually occurs pretty quickly after the onset of the fever. Most typically, it's a non-specific maculopapular rash, but also described the urticarial or evanescent rashes. These kind of almost looks like an allergic reaction kind of rash. Also described are sandpaper-like scarletiniform rashes. They've even seen multiform-like rashes, but this article is very clear. If your rash is bullous, with large blisters, small vesicles, or petechial, that is not a Kawasaki disease rash. It's primarily on the trunk and extremities. There can be some perineal accentuation and desquamation in that area, but again, that seems to be sort of secondary to the rash. The conjunctivitis is the most common finding in the United States. Typically occurs very soon after the onset. It's very prominent in the bulbar conjunctiva, but it spares the limbus. So right around the iris, there's an area of avascularity that it seems not to penetrate that area very well. It's painless, and again, the article takes pains to emphasize that there are no exudates and there is no photophobia. If it is, you have to look elsewhere. In this picture, you'll see right around the iris that there's this sort of pale area that's not typical of other forms of conjunctivitis, and this shows it even better, in which there's this sort of sparing around the limbus. The oral changes are usually, if they're present, fairly obvious. There's some deep erythema, cracking, peeling, fissuring of the lips. They describe a strawberry tongue, not just the redness, but the papillary, the taste buds actually kind of get sort of prominent. You get this sort of strawberry appearance at the surface. There can be just some diffuse erythema as well. And again, they take pains to say that exudates and ulcerations do not count as oral changes. And I've seen in this hospital sometimes people, oh, look at the oral change, they have Kawasaki disease. No, that's aptus ulcers, that's not Kawasaki disease. And here's an example of very prominent oral changes. And here's another girl with some cracking and fissuring in her lips, very red lips and red mouth. But kind of also notable, look at, she's that beautiful perilimbic sparing in the conjunctivitis. And the lymphadenopathy is the least common feature in the United States. Usually, we'll see more than one node. The instructions state that at least one node is above 1.5 centimeters, but I'm not sure I've seen this very commonly in my own experience. It's generally unilateral. The cervical nodes sit in the anterior triangle, usually a little tender and firm. They may be a little erythematous. I'm not going to belabor this differential. Many of us have seen this, but pointing out that the most common things we have to consider are viral infections such as adeno and enteroviruses, Epstein-Barr virus, all these enteroviral things. Toxic shock and staph and scarlet fever and measles seem to be the most commonly considered in the differential. They at least have to sort of be entertained. And again, just emphasizing what's not Kawasaki disease. So if you have a drainage out of your eye, that is not Kawasaki disease. If you have exudative pharyngitis, that does not count. Oral ulcerations, splenomegaly, and a rash of the vesicular, bullous, or petechial does not count. In reality, this is it can be very messy, right? I guess I hadn't considered this until this article, but they entertain the possibility you can have concurrent viral infections with your Kawasaki disease. They kind of say that if you have a patient who has the classic criteria for Kawasaki disease and you detect a respiratory virus, that doesn't eliminate Kawasaki disease. And I have to admit that I had often in my mind eliminated Kawasaki disease in my mind, but this article says no, you can have them concurrently, but again, emphasizing that if in conjunction with your viral diagnosis you have exudative pharyngitis, exudative conjunctivitis, it's not Kawasaki. They also make the specific sort of exception that if you have a nasopharyngeal swab positive for adenovirus from a nasopharyngeal swab positive by PCR assay, that is certainly going to be adenovirus and not Kawasaki disease. They also talk about cases in which you can sometimes have a patient who tests positive for group A strep, you give them antibiotics and they don't respond in the typical manner in 48 hours. We could at least consider Kawasaki disease in that spectrum, as well as retropharyngeal abscesses and phlegmons that don't respond to antibiotics because they may be kind of deeper manifestations of some of the lymph node changes that are associated with Kawasaki disease. For incomplete Kawasaki disease, unfortunately, most of our patients, many of our patients don't meet these classic criteria. And that makes I think, the crux of the difficulty in Kawasaki disease. The symptoms don't appear at the same time. They may be subtle or fleeting. They may masquerade as another condition. And this is kind of the real important part, because if this delays your diagnosis, that delays treatment, and that therefore increases your risk for aneurysms. And so this cartoon is kind of showing how things will occur over time. The fevers occur early. You may not see joint changes until later. In the acute phase, there might be some myocarditis, the aneurysms develop later. These changes in the hands and soles will resolve fairly quickly. You'll have desquamation that resolves fairly quickly, and long-term changes in your nail bends, and then platelets that occur later. So understand this is just one representation. There's variations on this, but you can imagine pretty easily how if some of these are missing or some are fleeting or transient and they really kind of come and go, that can really muddy the waters in our ability to diagnose it. So because of this dilemma, again, this paper emphasizes that they're trying to improve our ability to, in a timely manner, diagnose and treat these difficult patients, because this inaccuracy, this incomplete Kawasaki occurs more often in these treatments. Kids that are very young or the very old, and they're the ones who are at greatest risk of the aneurysm. So the very people who have the highest percentage of aneurysms are people who it's hardest to diagnose. So that's where the algorithm is pretty helpful. So to highlight that, here's a few cases. Here's some case reports. This is a 2-month-old who had a fever, conjunctivitis, rash, and bloody stools. This article describes a 2-week-old with fever, rash, conjunctivitis, and peripheral gangrene. That's an atypical feature. This child had 19 days of fever and no other symptoms, but all of them had Kawasaki disease as defined by giant aneurysm on echo. But if you look at that, none of them meet classic criteria, but these are the kids who are at greatest risk. And so the push of this kind of update is to try to simplify incomplete diagnosis, among other things. So we should consider incomplete Kawasaki disease in infants under 6 months who continue to be irritable with a prolonged fever, those who have aseptic meningitis that's otherwise unexplained with a prolonged fever, unexplained culture negative shock with an unexplained fever, adenitis that's unresponsive to antibiotics, and retropharyngeal phlegmon that's unresponsive to antibiotics. All of these have, and the three at the bottom are those that are really specifically brought out in this article that I had never considered in the differential. But the common feature is that they have incomplete criteria. They can be very young with prolonged fevers that are unexplained. This is the algorithm that was published in 2004 in the Neuberger article. In this article, well, it's a little complex, right? There's a lot of decision points. First, you assess your patient, and then you assess their labs. And then based on the CRP, there's another set of labs. And then based on that, you follow them clinically. And then based on that, you get an echo. And if that's negative, there's all these decision points, right? And you can imagine that working your way through this can add time and maybe not be necessarily very clear. So here's the new algorithm. There's really only one decision point. So if you have a child who has a prolonged fever and 2 or 3 criteria, but not all 4, non-classic criteria, you say, well, this could possibly be Kawasaki disease. Let's do some labs. The inflammatory markers are exceptionally common in the setting of Kawasaki disease. to the point that if they have a CRP less than 3 or a SED rate less than 40, they probably don't have Kawasaki disease, but it's reasonable to continue to follow them serially, check their labs serially. You can even get an echocardiogram if they've developed peeling or other kind of physical features that, again, in following them clinically, sort of make them appear to be Kawasaki disease. But on the other side of the category, if they have inflammatory markers, they're elevated, SED rate above 3, SED rate above 40 and CRP above 3, there's a series of labs. Just get these labs, and if they have 3 or more, they have Kawasaki disease, right? So there's no other decision points. Just get the labs if they have 3 of those criteria. None of those labs are specific. They're all non-specific labs. We're talking about anemia, platelet counts, albumin, ALT, white blood cell counts, and urine and white blood cells. None of those are very specific, but if you get a pattern where you have 3 or more of those in the setting of elevated CRP with a prolonged fever, that to these guys would count as Kawasaki disease, and you would treat them. Also, you may notice in the bottom, it also says a positive echocardiogram, and we'll address who gets an echocardiogram and what that means in a little bit, because that's an update as well. But the point is, they really simplified this, and the diagnosis still relies on clinical criteria. The lab tests are non-specific that can support the diagnosis. The elevated inflammatory markers are almost universal. Just to kind of as a note, IVIG can, in and of itself, elevate the SED rate. So once they've been given IVIG, we have to rely on CRP as a more accurate marker of inflammation after that point. But if you have the laboratory features, they should be treated as Kawasaki disease. The thrombocytosis that occurs, when you look at those list of labs, this thrombocytosis is one of those factors listed. The thrombocytosis is really prominent. It was over 700,000 in the 3rd week, sometimes seen. The criteria here says platelet count above 450, but sometimes they get really prominently high. Thrombocytopenia is rare, but if it does occur at the time of presentation, that's thought to be a marker for those at risk for aneurysm. The other labs, again, are relatively non-specific, but if you have 3 of them, that's a diagnosis. But again, they really try to emphasize that your clinical judgment is going to guide whether these children are diagnosed. It's clinically based. We may find additional system things that kind of come in your clinical judgment, not necessarily part of the criteria, but things that may kind of make you lean more towards diagnosing Kawasaki. There's a lot of GI findings, but would point out that in some centers, they'll get a abdominal ultrasound to look for high drops in the gallbladder, because in their mind, that's so commonly associated that that's a pretty big indicator in some centers. Arthritis, arthralgia, sterile pyuria, we've discussed a little bit. Common additional clinical findings, the irritability and aseptic meningitis is exceptionally common. These kids are very crabby. Interestingly, things I had not seen in my experience but described in this paper is sometimes you get transient Bell's palsy or transient sensorineural hearing loss. I didn't know about that. And again, we may see involvement in some of these other arteries. They commonly occur sometimes as long as a year after their acute illness. If they do occur peripherally, it's usually in the setting of those who have had coronary aneurysms. They generally present as pulsatile masses in the armpit or in the groin. The pathophysiology on a cellular level is very similar to coronary aneurysms, and the history is the same. But in this case, they generally don't develop a lot of symptoms because they collateralize so well around those obstructions. So that's why they don't present the way coronary occlusions do. Coronary occlusions result in death and bad morbidity. In the arm or leg, there'll be collateralization, and they won't have any sort of sequelae from it for the most part. And the Kawasaki disease can affect many systems, but again, it's the coronary involvement that is really the significant part. During the acute phase, we know that myocarditis is fairly common because it can affect the endocardium, pericardium, and myocardium. And this inflammation in the myocardium may start even before coronary aneurysms develop. The myocarditis I see in that initial echo, if I get a kid and I've done an echo in that first part and I see signs of just subtle signs, just a little bit of leaking from the AV valves or the aortic valve, a little bit of a pericardial effusion, kind of I get the sense that just this kind of cardiac irritability, a little bit of dilation, tachycardia, very mild, subtle evidence of myocarditis, but those are the ones in my mind as I'm doing the echo. I go, that's a real kid at risk for aneurysm. That's a true blue Kawasaki disease. But the valvular regurgitation tends to resolve after their illness without any long-term problems. EKG changes are subtle, uncommon, but may occur as well. Arrhythmia and ectopy may occur as well, but not very commonly. This is the important part, right? The aneurysms, if patients are untreated, a quarter of these patients with Kawasaki disease may develop aneurysms. 25%, that's a lot. But with treatment, we can reduce it to well south of 4%. As typically, these aneurysms occur in about a week and a half to 4 weeks after the onset of the fever, and the greatest risk patients are those who are very young and very old. If we could do a risk profile for aneurysms, and this is where the efforts in Japan are, because they're trying to identify in Japan those high-risk patients and find ways to really try to get ahead of their aneurysms. So we can identify the high-risk patients, and we can, at the beginning, treat them differently in a manner to reduce their incidence of aneurysms. That would be great. So out of Japan, we're finding that risk for aneurysm are most closely related to delayed delivery of IVIG. Again, those who are very young or a little bit older. Male gender, a significantly prolonged fever, well over 2 weeks, is a risk factor for aneurysms. If they have evidence of myocarditis on their initial echo, they seem to be at risk to develop aneurysms. These lab profiles, thrombocytopenia at the time of presentation, low albumin at the time of presentation, anemia, exceptionally high CRP, I think they said over 5, hyponatremia, white cell counts above 30, and cell rates above 100. Those are really significantly elevated inflammatory markers. But this is kind of a question, right? When do we order an echocardiogram? In the other algorithm, it was sort of incorporated in the middle stages in a couple of spots. Well, again, this is where the clinical judgment comes in, and your freedom has been, widened, broadened. So the only spot on here that you'll see any discussion of an echocardiogram is on the left-hand side. If you're just following them clinically, they don't seem to have Kawasaki's, but if they develop some signs or symptoms, especially if they have peeling, you should probably consider getting an echocardiogram. But they don't tell you why you would get an echocardiogram on the other side in the high-risk patients, because this article just simply says, if you think they have Kawasaki disease, if you are considering it, get an echocardiogram. That sort of scares me, because that means it's a lot of echocardiograms, but I'll be able to get a boat, right? So y'all go do that. No, but they really broaden this. I mean, they're really kind of unleashing your ability to kind of use clinical criteria and use an echocardiogram in the diagnostic process, which it wasn't before. Once we have made the diagnosis, all patients need a baseline echocardiogram, because that's what I use for future comparisons to see if they're developing coronary aneurysms. There have been times in which I find children who just have kind of funny coronaries, or they just have a broad origin or something that kind of looks odd. If I didn't see that at the baseline and I saw it later, I go, is that some kind of atypical aneurysm? So we get the baseline for future comparison. We have to keep in mind these kids are irritable, and it's hard for me to do that echo if they're screaming and they're fighting and they're rolling, and I'm trying to see something that's 2 millimeters in the cardiac cycle while they're screaming and thrashing. It's hard. So if we try to do this without sedation, we can certainly do that, but if I don't see the coronaries well, we have to sedate them so I can adequately see their coronary arteries. If you have gotten to the point, you said, this is Kawasaki disease, this article takes pains if the other didn't. This updated article says, if you have delays in getting the echo, the baseline echo, if you have technical limitations, don't let that delay your delivery of IVIG. Give the IVIG, this is the baseline echo. We can do this at 2 or 3 days of age. It doesn't really matter, we just have to get it at some point in the baseline. But don't let that delay your delivery of IVIG. Uncomplicated patients should have an echo repeated at, again, baseline. And this is a new part, and this is something I've always sort of felt is important, because In the old instructions, they said get a baseline echo and then one at 4 to 6 weeks. But meanwhile, in this whole time, we would treat them and put them on aspirin and say, we'll see you in 4 to 6 weeks. But what about the kids who are developing the aneurysms in the middle, especially if there's high risk factors? So I always sort of felt that it was sort of abandoning these kids by not doing an echo at 1 or 2 weeks of treatment. Well, the new guidelines have included that in their new instructions. And the idea is we're trying to pick these kids up as the aneurysms are evolving so we can kind of alter how we manage them a little bit more aggressive. And then for those patients who are having evolving aneurysms, we're going to be doing echoes twice a week or more until that aneurysm stops progressing. But the goals in this article, again, they harp on this early and often, that early diagnosis is important, early treatment is important, because by treating them in the acute phase, we're hoping to prevent aneurysms and hoping to prevent, and the goals of treatment are to stop this inflammation, number one, stop the inflammation, to therefore halt the prevention or to halt the progression of aneurysms, but also to prevent thrombus in this acute phase. Long-term management and managing those who do have aneurysms is focused on trying to prevent ischemia and myocardial infarction. So in classic KD, treat as soon as possible. It's based on clinical criteria. Don't wait for the echo, right? In incomplete Kawasaki disease, the algorithm has been simplified, but the idea is to capture more patients. This article says we recognize that there will be false positive diagnosis of Kawasaki disease. We recognize the fact that this is going to capture more patients, some of which may not have Kawasaki disease. But the risk of IVIG is far lower than the consequence of developing a coronary aneurysm. So the idea is that they would rather capture more false positives than lose the false negatives. So IVIG, there's nothing that's had a bigger impact on Kawasaki disease than IVIG. This is from pooled human plasma. It includes all immunoglobulin subclasses, a broad spectrum of antibodies to a broad spectrum of antigens. And it has this generalized anti-inflammatory effect. We don't know why it works. We don't know if it's affecting B cells or T cells, or if it's sort of binding a toxin or some agent itself, or whether it's affecting the T cell or B cell line. We don't know that, because I don't think we know what's causing Kawasaki disease. We prefer to give it within 10 days, and a single dose has been shown. They did a lot of experimentation early in the history of Kawasaki disease to try a variety of divided doses. But they showed that a single dose of 2 grams per kilogram over 12 hours is far more effective than divided dosages. We probably should avoid giving the live virus vaccines for 11, 12 months after IVIG, not because it's dangerous, but because the IVIG may bind those live virus vaccines and make them ineffective. But if you have somebody who's exposed to measles, then the risk of measles may be greater. You should still immunize those kids for measles, acknowledging that they may not develop full immunity to that vaccine as long as you re-immunize them past that period. You can still give IVIG beyond that 10th day if there's evidence of ongoing inflammation marked by inflammatory markers, if there's a fever, or if you do an echo and there's an aneurysm. So if you're kind of 12 days out and you've gotten an echo, you say there's aneurysm, they should still get IVIG. If they're 12, 14 days out and they're still having fevers and there's evidence of inflammation, they should still get IVIG, even if they're past that 10 days. Do not give it, though, if there is normal labs, no inflammation, no fever, no aneurysms. That train has left the station, it's already at the next spot down the road, and you have missed your window of opportunity in that case. And treating them with IVIG past that point is of no benefit. Aspirin it's used for its anti-inflammatory and anti-platelet properties, but it clearly does not decrease the incidence of aneurysms. So the dose is controversial. In Japan, they use a different dose than we do here in the United States. And there's no clear evidence that the high dose is really necessary. It's really kind of a mixed bag. But they've still stuck to their guns in this paper, and they still say that high dose aspirin should be given at 80 to 100 milligrams per kilogram divided 4 times a day during the acute phase. But the duration has not been defined by this paper. The maintenance dose is converted down to a lower dose after some indiscriminate period, and then continued until we do our echo at 6 to 8 weeks. If at 6 to 8 weeks they have no aneurysm, we'll stop the aspirin at that point because they didn't develop aneurysm. If they do have aneurysms at 6 to 8 weeks, we will continue the aspirin indefinitely. The duration of high dose practices vary depending on where you're trained. Some people just arbitrarily say after 2 or 3 days after your fever is gone, we'll convert you to a low dose. Some people have done it for 2 weeks. In Japan, they do it for 2 months, relatively high dose. Granted, not the same high dose we do, kind of a half of the dose we do here, but they'll do high dose for 2 months, but the incidence is higher, the consequences are greater. The inflammatory, some people continue aspirin until the inflammatory markers have normalized. I used to do that, but found that it was hard to get the labs and the follow-up, and in the end, parents just stopped giving it a lot of times. The recommendations do not require you to get aspirin levels. It is not part of the protocol. But if you do, the target range is 20 to 25 milligrams per deciliter, but that aspirin levels are not part of either the old or new protocols. So this is kind of discussed in the new paper. So if aspirin's not going to reduce the incidence of coronary aneurysms, if aspirin is questioned whether it's necessary, why is it being given? Well, it does have an anti-inflammatory benefit, and studies have demonstrated that if you give aspirin in conjunction with IVIG, that the combined effect is actually somewhat synergistic. You actually get a bigger impact of your IVIG if you combine it with aspirin. And also, I think this, in my mind, this is the important part. It has the antiplatelet properties at the time the aneurysms are developing. And so it sort of prevents the aneurysms or clotting in the aneurysm at the time they're developing, at the time the platelets are high, at the time they're anticoagulable. And so to me, that's the benefit of aspirin. There's some discussion in the past about Reye's syndrome. It has not been associated with low-dose aspirin, but at higher dose aspirin, it occurs as a result of varicella influenza while they're getting aspirin. Fortunately, it's rare, and in those who have gotten Kawasaki disease and are on aspirin, it's occurred exceptionally rarely, but not at the low dose. So I think that's why some people are converting to the low dose relatively early, especially since we're not convinced that we know exactly when the high dose should be given. This is something that was talked about in the paper because some of the panel members are from Japan. They thought that it was important to sort of bring this, that in Japan, their efforts to risk stratify patients at the very beginning, to identify those at highest risk, and at the time of primary treatment, try to find something that in those high-risk patients will sort of diminish the incidence of coronary aneurysms. But the protocols vary. The problems identifying who's at risk, and the protocols vary in identifying that. The treatment protocols vary. It's still under investigation, but it's unfortunately very muddy. Some of the protocols call for using corticosteroids and infliximab, or I'm not even familiar with this medicine, the etanercept. They're all still under investigation. We've had mixed data on whether or not treatment with corticosteroids in addition to IVIG in the beginning part is really very useful. The data's been mixed, but if you feel that you have a high-risk patient, you have myocarditis, it's a male, they have low platelets at the time of presentation, they have very high sed rates, very high CRPs, you know, man, this kid's really at risk. There probably is justification to giving corticosteroids as an adjunct in the beginning part, but understand there's not a lot of data to support it, but there's also not a lot to say it doesn't help. In those cases with IVIG resistance, this paper does spend some time talking about what to do in the case if your patient doesn't respond and they continue to have a fever. About 10 to 20% will have a persistent or recurrent fever after initial treatment. It seems to be that those patients are at increased risk of getting aneurysms. So in the current era, the data is still not robust enough to really give you a clear choice on what to do in that case. The paper still states that retreatment with IVIG at the same dose, 2 grams per kilogram, is probably the most commonly done and probably the most effective, and there are many retrospective studies that demonstrate that benefit, but it's never really been demonstrated adequately in a prospective study. Now, that being said, there seems to be a lot of data to show that this is helpful in the bulk of patients who fail their initial course of treatment. Corticosteroids seem to be the next most common secondary treatment protocol. Again, there's no good studies to compare different regimens against each other or those regimens against IVIG. There are some that talk about these high-dose pulse courses. and others with a kind of a longer, lower, but tapering course. Again, no clear evidence to show which protocol is better or if it's any better than IVIG, but understand these are just choices in your armamentarium. Kind of down from there, third line treatment, they talk about infliximab, that they clearly have shown reduction in inflammation, but thus far it has not reduced the incidence of coronary aneurysms. So it may not be any better than what you've done already. In truly refractory cases, they've even described the use of chemotherapy agents, this recombinant IL beta receptor antagonist, which is pretty new, plasma exchange even. These are the ones you've seen to just have very, very high ongoing fevers and high risk for aneurysms, even those who are developing aneurysms over time. And then the other parts of this paper that are sort of expanded that I'm not going to touch on, there's a lot of stuff for us cardiologists. They go into really fine detail on what is an aneurysm, how do we define it, what are the measurements, where do you make the measurements at, which measurements databases do we use, which body surface area protocols do we use to normalize that data. It's a long discussion, but that's really targeted us, not you. Also in here is a very long section on how to manage anticoagulation, because there's a lot of new agents on the market that were not previously available in 2004. In the old article, they just said give them aspirin, and if they have aneurysms, consider warfarin, Coumadin. This goes into this huge protocol. There are many categories and subcategories and combinations. That's for us, not you, but just understand that's been an area of expanded discussion in this newer paper. And also how to treat an evolving MI and thrombolysis. Even as a cardiologist, I can tell you in my career, I've never seen an evolving myocardial infarction. So even though I'm the one who's supposed to be doing this, we don't do it very much. And so it's nice that this article reviews sort of the current literature on how to handle evolving thrombosis. And again, I just want to bring up this picture to kind of say there's a spectrum, and that it all depends on whether or not you've developed coronary aneurysms, and that determines our long-term outcomes and our long-term management. In large part, the outcomes depend on this, whether or not dilation occurs. If you have small aneurysms in ectasia, we see normalization of coronary arteries, and we are confident now, at least as much as the data will allow us. Understand this first diagnosed in '67, our current treatment protocol started in back the '80s. So we're talking about these kids who are 2 years old in the '70s and '80s are just now getting to be 40 years old, right? We don't know a lot of information is going to happen, so it's kind of be an ongoing study, but the data we have thus far is if you had no coronary dilation, you seem to have no increased risk of myocardial infarction as an adult based on the data we have right now. That may evolve in another 10 or 20 years, but at least right now, if you had no coronary changes, they're normal kids. If the luminal dimensions normalize in medium or large size aneurysm, again, it's important to understand the architecture of those arterial walls is not normal. And that process may progress over decades to kind of cause stenosis or occlusion long term. And the giant aneurysms do not normalize. So this is kind of a table in which they have stratified the patients. I know it's a busy slide, it's kind of small, but kind of what they're doing in this table is they're saying, okay, category 1, no coronary involvement. Category 2, transient dilation that went away. Category 3, small aneurysms. And that's broken down into whether or not those small aneurysms went away. The next category, medium-sized aneurysms. And again, breaking it down into subcategories and whether or not they went away or whether they persist. And then category 5 is broken down into 4 subcategories, again, depending on what's going on with those. Before, there used to be just 4 categories of long-term follow-up. Now we have 14. So they've really tried to define how to follow them long-term. But the coronary artery, the degree of coronary artery involvement then dictates how we perform surveillance in long-term. For you in this group, all you have to worry about are the first 2 groups because everybody else is going to be followed by a cardiologist. The first 2 groups, in level 1, this top row, those are those who had no coronary involvement. And as we go across, we'll see that they are discharged from cardiology within 4 weeks to a year. So we're not going to see they're not going to see a cardiologist if they had no coronary involvement. They're going to see you. So they're going to be discharged from cardiology. We don't have to kind of worry about long-term issues regarding MI. We don't have to do any further cardiovascular assessments. They should continue to come back and get their blood pressure checked, get their lipids checked, kind of check their diet, their weight, kind of reasonable long-term screening for MI risk, but not because they're increased, but because it's just sort of dotting I's, crossing T's. I still think it's evolving over the next 20 years. What's going to happen to these kids with Kawasaki Disease as they get to be 50 and 60 years old. There's health promotion counseling at every visit and age-appropriate counseling regarding production, but no modifications to that. In the second category, where they had a little bit of dilation, like these transient subtle dilations, occasions that went away, they may continue to see cardiology beyond that, but otherwise everything else is the same. You're going to be following those patients, but there's no issues that you have to really kind of be worried about. Then in this category, top line is just going over who needs medicines, and you'll see that the category had no coronary involvement, they're not going to be on aspirin, they're not going to be an anticoagulation, they're not going to be beta blockers, and they're not going to use statins. And then the second line, if there are transient dilations, maybe we can do aspirin long term, like baby aspirin every day, but even that's not really conclusive, and again, no medications. So if they've had little or no coronary involvement, you'll actually be the ones following them, but there's really nothing that we're really worried about for that category of patients. Anybody who did have significant medium-sized or bigger aneurysms are generally going to be followed by cardiology. I think I've kind of gone over this, so I'm going to skip it. So in summary, thanks for hanging with me, guys. I know it's been long. So Kawasaki disease is a clinical diagnosis. The labs may help support your theory, but this is clinical criteria. These are diagnoses you make, the early diagnosis is important. Not much has changed in terms of epidemiology. We're still not sure if these tropospheric air currents are going to be a significant issue or not. Their thought was, since these currents are kind of in the northern hemisphere, that would explain why we're seeing the northern hemisphere and not the tropics in the southern hemisphere. I don't know, it'll pan out maybe. But there's still ongoing research into epidemiology and causes. The etiology is unknown. And again, just to review, our thinking now is that Kawasaki disease is a common endpoint due to something related to an infectious process with some impact on the environment in genetically susceptible individuals. It's sort of like this mishmash, perfect storm sort of phenomenon. We are identifying genetic risks, genetic markers. This is creating a lot of excitement because we're hoping that we can find allele-specific treatments, allele-specific risks, allele-specific research or treatment or diagnosis. We're not there yet, but you know, again, it's a whole bag that's sort of been open to us. The diagnosis of classic Kawasaki disease has remained unchanged since the 60s, but the really difficult ones are the incomplete Kawasaki disease, and as we kind of showed, the new algorithm is hopefully less complex, more user-friendly, utilizes your ability to use clinical criteria, and in process of making it faster and easier, that'll lead to faster treatment and less aneurysms. And they acknowledge that we may capture more patients and more patients may get IVIG, but the risk of IVIG is far less than missing a coronary. Echocardiograms now are a bigger part of this, and simply they're saying if you are worried about Kawasaki disease, get the echocardiogram. That may be part of your diagnostic process in those with incomplete Kawasaki. It's not part of the complete Kawasaki. Those with classic Kawasaki, you just drive on and treat them. This is more in the role, if it's an incomplete case, it is now thought to be more of a role in the diagnostic process than it used to be. We've added an echocardiogram in the routine follow-up in 1 to 2 weeks. The acute treatment hasn't changed. There's been some discussion of adjunctive therapy. Maybe there's a role for steroids in high-risk patients, but not a lot of data to support it. In IVIG-resistant therapies, IVIG is still the first option for retreatment. Steroids are the next best option, and others kind of go down the road. If you need to, we can refer the article. A resolved aneurysm is not resolved. The internal lumen may normalize, but the arterial wall is not a normal arterial wall, and there's a long-term risk for thrombosis or stenosis, and that's in our hands as cardiologists. If you have somebody walk in and say, yeah, I had Kawasaki disease 10 years ago, but I don't know what's going on, that might be somebody that you need to refer back into us, right? The long-term prognosis for unaffected coronaries is likely normal. Those who had no coronary changes are likely to be normal long-term. And long-term management or risk stratification is sort of based on whether or not they had coronary aneurysms. But the first two categories are in your hands, but don't require a lot more than routine serial counseling, screening of lipids, and watching your weight and blood pressure. Common sense stuff. And now, just as I mentioned again, there's a group of patients now entering their 40s and 50s who are under the old guidelines. They may have been missed and have a clean bill of health, but they're probably having some long-term risks, and again, can be referred back to us if there's some concern for that. And I think that's it. Sorry.
I have two questions. The first one, if you have a child who presents like presentation late presentation Kawasaki, is there like a treatment window where treatment then
well, it was addressed in the paper. Yeah. So if the thought is that IVIG is going to be most effective within 10 days of the onset of the fever. If you're outside that 10 days, you can still treat them with IVIG, but usually indicated for those who have an echo that's abnormal, those who have ongoing fevers past that 10 days, and those who have signs of inflammation past that 10 days. So if you have any of those criteria, that the child is still sick, still having fevers, or have aneurysms, they should get IVIG. If you're past that 10-day window and they don't have aneurysms, don't have fevers, don't have inflammation, there's no benefit to treating them with IVIG past that point.
Second question, in medium vessel vasculopathy, like something EMR any evidence that
they talk about it here, but it's not clear. There's some supporting data, some that's not. Even in Japan, where they're doing it a lot, they're still trying to risk stratify these kids and use these adjunctive therapies, but nothing's been really clear thus far.
That was a very nice review. I'm old enough to have been a fellow in Seattle the first day of the planning program, putting an IVIG program. I wanted to emphasize to the students and the rest of something you pointed out that, fortunately, young people they are the ones who are most likely to have incomplete all that atypical. Fortunately, it's very good for young people incomplete forms. They have the highest risk.
Absolutely.
Very frustrating not to have better language. Please think about Kawasaki. Quote, FTO, could be on your radar, even if they have nothing except fever.
Exactly, and they stress this many times in this article that the prolonged fever alone should sort of leave this on your radar screen.
And my other comment was, the only thing I don't like about the new guidelines is, I think high-dose aspirin basically one of those. Because I agree with them, no evidence that you improve long-term outcomes. There's some risk of high-dose aspirin. And this is a question from not low-dose aspirin interferes with platelet function, but high-dose aspirin doesn't. You're not necessarily getting that benefit right from aspirin at very high time.
I think the benefit, the reason why it's still included, high dose, is for this sort of synergistic effect with IVIG, that you're trying to actually get a boost to this anti-inflammatory effect to arrest the development of aneurysms. In Japan, they're using a dose about half of what we do. It's still high dose. It's still higher than 3 to 5, but it's more in range of 35 to 50 milligrams per kilogram instead of 80 to 100. So it's still a high dose, but it's not as high dose. Whether that's appropriate or more effective, I don't think we at least in the United States, have sorted that. So I think the role for high dose, it may be appropriate to use a smaller high dose like they do in Japan, But I think that they're trying to take advantage of this sort of anti-inflammatory jolt to stop the development of aneurysms. I think that's why a lot of people now are sort of converting to low dose fairly quickly. You know.
Started doing it in this
Right, exactly. So
12 or 24 hours of high dose.
and I think the bulk of programs are doing that. They did that when I was in South Carolina. We did it in North Carolina, and then we did it, you know, when I was in the program in San Diego as well. I think that's becoming more common to just simply arbitrarily at 2 or 3 days after a fever convert to a low dose, and then that antiplatelet effect sort of prevents the formation of thrombus until you're sure whether or not they have aneurysm.
I mean, it's almost a fluke with high dose protocol. What was happening was people in chronic places, chronic high dose therapy, or IVIP, did that study they thought, but people are already using aspirin for later included in the study design. But within the study design, aspirin, well done.
All right, any other questions? All right, thanks everybody for your patience. Have a good day.